All right, so again, if you guys have any questions about what I'm talking about, if I'm not being very clear, please raise your hand and I can try to be more descriptive in that. So we're going to go to start on slide 2. All right, so lecture 3, this is the big one. This is very, very important for understanding of things like hypertension. We talk about CHF and things like that, or congestive heart failure. Really, really important that we have a good understanding of cardiac output, talking about blood volume and how that's managed, and then looking at things like vascular resistance and then how that informs blood pressure in general. Okay, I'm going to go to the next slide. So we're going to be discussing the cardiac function and vascular regulatory systems. The next slide, and then the next. Okay, so what is cardiac output? We'll say that this is going to be a product of two things. It's going to be basically the blood that gets pumped each minute by the ventricle. And mainly we're going to be discussing which ventricle? The left one, right? That's the one's doing the majority of the work here in the body, circulating blood around. And you'll see that cardiac output is going to be the major constituents of what determines what your cardiac output is. And you can multiply these two factors together to get what your cardiac output is. Usually this is going to be in milliliters per minute or liters per minute. Okay, so you may see either of those two units being used there. But it's going to be a factor of your heart rate, defined in beats per minute, and then your stroke volume, or SV, it's going to be in mLs per beat. And it makes sense if I take how many times I'm beating the heart and how much blood is being ejected with each beat. It'll make sense to see what the total amount of output out of the heart is at any given time. Okay. We're going to see some of the individual factors that go into determining what your cardiac output is. So some of the things that will be affecting cardiac rate. We said the parasympathetic nervous system normally does what to heart rate? Should decrease it, right? And then we said sympathetic nerves do what? Should increase it, right? Because it's going to be your fight or flight response. We want to be able to get more blood to our skeletal muscle tissue so we can run away from the titular bear that we talked about previously. Stroke volume is going to be a factor of a couple other things. So this will be some of the newer stuff we'll talk about here. It has to do with contraction strength. So how strong of a contraction you're going to get. You guys know what the term for that is? It's going to be inotropy. So yeah, so we'll talk about inotropes, positive and negative inotropes, as we go forward. But that will affect the actual contraction strength or contractility of the heart. We'll also talk about the end diastolic volume. What do you think end diastolic volume is, if you had to define it?
The volume of blood.
All right, so the amount of blood in the ventricle at the end of diastole, right? Not at the end of systole. In systolic volume is going to be a different thing, which we'll look at what those mean in just a little bit. So based on this, you'll see that having a larger amount of blood within the ventricle causes that muscle to stretch more, right? Because more blood in there, and it has to fill that space. It's going to stretch that heart muscle, and that's going to lead to this kind of Frank-Starling mechanism that we're going to talk about. And that will lead to more cardiac stretch of the ventricles, and then that's going to lead to better strength contraction. Okay, so we'll look at that in just a little bit and how that affects stroke volume and our cardiac output. And then we'll also see a mean arterial pressure is going to be involved here. And so what do you think? It says dashed line probably means it has a kind of an inhibitory effect. So why do you think blood pressure could have a negative effect on the stroke volume? Right, so if I have higher blood pressure in the vessels, what do you think that does to stroke volume? Should decrease it, right? Because we're having to pump harder against that pressure in order to get that same kind of flow, right? So you're going to find that the higher the pressure is in the arterial system, the venous system, throughout the body, you're going to find it's going to have a negative effect on stroke volume, okay? And so that's going to be important when we talk about the concept of afterload on the heart, okay? And this is a big thing. A lot of people have chronic afterload problems. They have chronically too high blood pressure. We're going to see that has some negative effects on the heart in the long term. Okay, so we mentioned that as far as regulation of cardiac rate, the actual pace is going to be coming from kind of the net effect of these antagonistic systems here, right? So it's not like you're going to have zero parasympathetic and all sympathetic. Usually it's kind of a balance between the two at any given moment. So depending on what the situation is, it may be leaning towards one side or the other. And we said that things that have positive chronotropic effects, and when we say chronotropes, what does that do to the heart? Yeah, it should change the rate, so either speed it up or slow it down. So positive chronotropes are going to increase cardiac rate, whereas our negative chronotropes are going to be decreasing that cardiac rate. Okay. So looking at the effects of the parasympathetic and sympathetic nervous system on the heart, we're going to see several different tissue areas. I'll see sympathetic effects here, parasympathetic nerve endings here, what that does. So we mentioned the SA node and the AV node, that we should be seeing the sympathetic nerves doing what to the heart? Increasing rate is going to be helping by usually changing the resting membrane potential. Do you think it'd be raising it or lowering it on those pacemaker cells? Should be raising, should be making it more positive, right? Because that means that you're closer to that threshold to cause a depolarization, okay? Right, so we'll see how the parasympathetic nerves are doing the opposite effect. But essentially by increasing reducing that threshold for depolarization, you're going to cause an increase in heart rate, right? So that's going to be through this pacemaker tissue here. You'll see that the conduction rate is going to be going up, and in general, just increased rate here. As opposed to the parasympathetic nervous system, we mentioned that the parasympathetic nerves are going to be working through which neurotransmitter primarily? Acetylcholine. It's working on what types of receptors? Muscarinic receptors. And what does that do to those pacemaker cells? Yeah, it's going to lower the resting membrane potential, making it more negative. How does it do that? Do you guys remember? Yep, it's going to open those potassium channels. It's going to allow potassium to flow along its concentration gradient outside of the cell, go from in to out, and that's going to make that resting membrane potential more negative and more difficult for those cells to get to an actual potential threshold. So that's basically going to be slowing down the heart rate. Notice the parasympathetic nervous system doesn't have a ton of effects on the actual muscle itself, so you don't really get many changes in inotropy from the parasympathetic nervous system so much. You will see definitely some good effects here from the sympathetic nerves, where if you have increased activity, if you have increased amount of, and what neurotransmitter gets sent through the sympathetic nervous system? Yeah, epi and norepi are two of your primary ones. They're going to cause increased strength of contraction. Okay, so you're going to see bigger squeeze on the heart. You're going to see that stroke volume is going to be going up. Your cardiac output should be going up as well, right, by increasing the squeeze of the muscle. Oh, and so when you're looking at the parasympathetic nervous system, you're absolutely right. It's releasing acetylcholine onto muscarinic receptors, right? Acetylcholine also affects nicotinic receptors. You see that a lot more with like neuronal communication at different synapses. You're going to see that a lot with skeletal muscle transmission, so especially at the neuromuscular end plate. That's all through nicotinic acetylcholine receptors. We'll see that the sympathetic nervous system is releasing that epinephrine, norepi onto adrenergic receptors, right? So we'll talk about our beta receptors. We'll talk about alpha receptors and how those are going to respond to that sympathetic nervous system outflow. Let's see how that has an effect there. So thank you for clarifying that. So anyway, so we said that the regulation of stroke volume is going to be through these three variables. So one of them is going to be the end diastolic volume, that EDV, basically the volume of blood in the ventricles at the end of diastole. So this is kind of like when the atria gets squeezed and kind of put the most amount of blood into those ventricles, what that end diastolic volume is going to be. And this is considered preload. Okay, so it's really important to understand the difference between preload and afterload, especially when we're talking about the actual pathophysiology of some of these cardiovascular disease states. Preload is ultimately defined by, or determined by, the venous return. So if you have a ton of fluid coming back from the venous system into the, which side of the heart? Right side of the heart, and then goes into the lungs, and comes back to the left side of the heart. If you have a lot of return there, you're going to have a lot more blood within the ventricle, and that's going to increase your end diastolic volume, which in turn is going to increase your stroke volume. Okay. And as you can see, stroke volume is going to increase with an increased EDV up to a point. You're going to see that with any of these systems, you can overwhelm them, and that's when we run into disease that can occur. Okay, especially when you see kind of chronic changes to the heart. Because if you're chronically overworking the heart, you're going to see certain changes that happen. It's going to become more fibrous. It's going to be less compliant. It's going to be more hypertrophy. You're going to see changes that occur over time. But in general, as you increase stroke volume, you're going to have an increase in your EDV. Those both will be proportional there. Okay. You'll see that stroke volume can also be regulated through contractility, or this inotropy, and basically that's just the strength of that ventricular contraction. So positive inotropes are going to cause a better squeeze or stronger squeeze there. And as you have increased stroke volume, or you'll increase your stroke volume when you have an increased contractility. So if I were to, say, pour epinephrine into the bloodstream, that hits the heart, it's going to cause that to squeeze harder. It's going to cause more blood to be ejected out. Stroke volume goes up. Okay. And then finally, this third effect here, this is going to be your afterload. This is going to be total peripheral resistance, or TPR. is going to be basically determined by your blood pressure, essentially, right? So this is the frictional resistance in the arteries that basically impedes that ejection of the blood from the ventricle. So kind of you'll see usually the highest pressure is around the aorta, and if you have too high a pressure, you're going to impede that blood flow out of the ventricles, right, coming out of that semilunar valve. If you impede that, it's going to make it so that your stroke volume will typically do what? So higher TPR will do what to stroke volume? Should go down, right? Because those are going to be inversely related there. So increases in TPR, you're going to see decreases in your stroke volume. Basically, it's kind of like putting a kink in a hose, right? You're kind of blocking that flow of water through that garden hose at that point, right? You'll hear me talk a lot about garden hoses and response, kind of talking about the cardiovascular system. So looking again, preload is going to be determined by this venous return to the heart. You can see that some things that can affect this. So for instance, if you had hypervolemia, what is hypervolemia? Yeah, increased blood volume, you got too much volume on the system. What are some cases where people might have hypervolemia? Overhydration, so they drink too much water maybe? Or some other cases? Yeah, renal failure could be another big one. So if you have problems excreting water, that could be a reason why you may hold on to too much, and so you can actually have some hypervolemia from that case. So you'll see that a lot of these patients are going to have issues, especially those that have like congestive heart failure. Over time, you're going to have a harder time pumping that blood out, so you're going to have congestion that occurs, especially on the venous side. You're going to have a lot of fluid that's kind of being held into the interstitial space and things like that, and that's going to all be affecting your preload. So again, regurgitation of the cardiac valve. So if you have blood that's flowing inappropriately, you can see that may be affecting the venous return into the heart. That can all be affecting your preload. On the other hand, you have your afterload. Again, this is the resistance. So again, notice this little clamp here on the aorta. It's preventing blood from flowing out. Increases in TPR should cause a decrease in your stroke volume, and so you can see this would be typically is going to be increased in things like hypertension, or just in case we have like vasoconstriction kind of in general. And so increased afterload means increased cardiac workload. It's harder the heart has to work in order to keep that cardiac output the same. Because again, your body likes homeostasis, right? So if you get into a case where your TPR is going to be going up, causing your stroke volume to go down, the heart still wants to have that same cardiac output, still wants to maintain a normal cardiac output. So we'll see some of the compensatory things that it will do to try to maintain that. All right, so you can look at your stroke volume is just basically going to be, can also be calculated by your end diastolic volume, which should be a larger number than your end systolic volume. And what do you think end systolic volume is? So the blood left over in the ventricle after it's squeezed, right? So whatever kind of residual you have there in the ventricle is going to be considered your end systolic volume, okay? And we can see how some of these different things by affecting our inotropy, or our preload or afterload can have effects on our end diastolic and end systolic volume. So in these cases here, you have an increased preload, so increased venous return, more fluid returning back to the heart. That should cause increases in stroke volume, right? So that would mean your end diastolic volume should be going up because you have more coming back into the ventricles. Makes sense. If you have an increased afterload, or the blood vessels are going to be too constricted, preventing blood flow, you can see that decreases your your stroke volume here. And that's going to be leading to an end systolic volume that's going to be higher, right? So basically, even though the heart's squeezing, if it can't overcome that pressure, you may have extra residual left over in that ventricle, okay? And then, or to increase inotropy, that contractility, that should increase my stroke volume, and that should decrease my end systolic volume there in the ventricle, okay? So you can see how these are kind of working against one another, and that's oftentimes what the heart will do, is if you have an increased afterload, the heart's going to want to beat stronger in order to keep that end systolic volume the same, right? So I like to maintain homeostasis, we want to make sure cardiac output stays maintained. And if I decrease my stroke volume, what does cardiac output do? Goes down, right? So we mentioned that cardiac output is going to be equal to our heart rate times stroke volume, right? So we got to make sure those are maintained in order to keep cardiac output regulated. Everyone's still with me. Everyone can hear me appropriately. Yes, sir. Say it again. The inotrope, yeah. So basically, imagine if you were trying to, I think something like squeezing, but basically it's making that muscular contraction stronger. So for instance, if you were trying to, cannot think of a good analogy right now, but basically, you're increasing the squeeze of the ventricles. So by increasing that squeeze harder, that's going to be forcing more blood out against that pressure. So basically, the pressure in the ventricle would be higher to compensate for the increased pressure in the aorta and the rest of the blood vasculature. Make sense? Usually I'm better coming up with analogies, but this has been a weird day, so you have to forgive me. Okay. So we mentioned that Frank-Starling, who sounds like a good name for like a TV show detective, but this is actually two different physicians who came up with this law for the heart. Basically, they were saying that when you have an increase in end-diastolic volume, you should see an increase that's commensurate in contractility, and that's an increase in stroke volume. So essentially, when the ventricles detect that they are being stretched more by having a larger end-diastolic volume, they're going to respond by squeezing harder. So they want to make sure that the inotropy is going to be proportional to that end-diastolic volume so that you can squeeze out all that blood. Because basically it wants to make sure you don't have a lot of end-systolic volume left over, and we'll see some cases where that is going to occur. So again, when we need to pump more blood to get more oxygen delivered throughout the tissues, this is going to come into play here. Because again, as we are getting to, if we're trying to run a mile or something, our sympathetic nervous system is kicking in, we're going to have a lot more venous return to the heart, which means we're going to have more ventricular dilation. We're going to have more of that muscle being stretched. You're going to want to respond to that appropriately by squeezing harder to get that blood out, because obviously you need it for whatever purpose. So you can see as the stroke volume here on the y-axis, you're going to get ventricular end-diastolic volume here on the x-axis. So as it increases, you're going to see that the stretch is going to lead to an increase in your stroke volume there. That should make it so that your end-systolic volume should be roughly the same regardless. Make sense? You'll see that sympathetic nervous system stimulation is going to be a big thing that helps to regulate this. As mentioned, the parasympathetic nervous system doesn't do a ton on the actual inotropy of the heart. It really only helps with the actual heart rate, whereas the sympathetic nervous system affects a lot more of that contractility, allows it to squeeze harder. So you can kind of see how, in this case, when you're looking at cardiac output as a whole, made up of the cardiac rate times the stroke volume. You see here, sympathetic nervous system has a good role to play in both of these factors. As I have increased venous return, as I have an increase in end-diastolic volume, that's going to lead to more of that stretching in the ventricle, which is going to lead to better contraction strength. Okay, so the sympathetic nervous system responds to that stretch in the ventricles when you have increased EDV by increasing the contractility, so that way you get a good increase in your cardiac output, right? Because we don't like to leave a lot of blood sitting around the ventricles. It should be getting circulated through appropriately. Okay, so looking at venous return, you can see that the end-diastolic volume is controlled by that total blood volume, okay, and also the venous pressure, kind of that driving force for blood return. And how do you think venous pressure relates to like arterial pressure? Lower or higher? Much lower, right? So your venous pressure is generally going to be a lot lower than your arterial pressure, and so we would consider that kind of a low pressure system. And again, that makes sense when you look at like the heart, like the right ventricle is a lot smaller than the left ventricle because it doesn't really pump as high pressures in order to make sure it's circulating that venous blood flow. We'll say that the veins have high compliance, which means that as they get a larger volume instilled into them, they're going to be able to stretch it a little bit better than given arteries. Right? So as the vessels are able to stretch more, they can hold that volume, they can hold a higher volume without increases in pressure, essentially. So you'll notice that when you're looking at where the blood is in the body at any given time, you have a large amount of it sitting out in the venous system, and it's kind of low pressure system waiting to be circulated around. Versus in the arterial system, those vessels are much less compliant, which means they're not going to be able to stretch quite as much in order to maintain that high systolic pressure. Okay. So again, the veins, we mentioned about 2/3 of the total blood volume is going to be located in the veins at any given time, and they're going to hold a lot more blood than the arteries, but they maintain that lower pressure, right? So they're basically going to be kind of more stretchy, allow for more blood to be held there in those vessels. So again, looking at how we can manage our venous return, so looking at blood volume, you'll find that the kidneys have a big role to play in blood volume. If you were to have, say, kidney failure, if you were to stop all kidney blood flow at a given time, you'd have all that volume just being held onto, and that would increase venous return for sure. You also have the tissue fluid volume as well. So for some patients who can't circulate around this volume very easily, if you think about like certain liver patients or patients with CHF, they hold on to a lot of fluid, and so that's all in the interstitial space between those different cells. And so again, that all has to be circulated through. So again, that increased blood volume as well increases your end-diastolic volume. So you'll see numerous examples of that as you move forward in your clinical career. You can see that breathing is going to have an effect on venous return by causing that negative intrathoracic pressure as you inspire. That's going to help to change the pressure in that system. And then again, one of the big things we'll focus on here, especially in cases like hypertension and whatnot, is the sympathetic nerve system stimulation. This causes increased vasoconstriction. That's going to lead to increased venous pressure, and that allows for more blood to be circulated through and return back to the right side of the heart. Also, skeletal muscle pumping will also help to move this blood along a lot better. Okay, so more of the muscles moving around, like if you're in, especially like in a fight or flight scenario, more venous return is going to come back to the heart. So this is kind of a good graphic kind of showing you where the blood in the body is at any given time. I mentioned you're around 10 to 12% sitting there in the lungs. Can you think of any cases where you might have extra volume in the lungs? CHF might be one. You know what you call that when you have fluid in the lungs? Yeah, I call it pulmonary edema. So basically, if you're having an issue to where you're having too much back pressure on the lungs and not enough fluid is able to circulate out, you have all that fluid accumulate in the lungs, which is going to then, we'll look at the respiratory system in a few lectures, but all of that is going to kind of accumulate in the alveoli, can impede oxygen exchange. So we don't like that to happen, right? We want to make sure we don't have pulmonary edema, but around 10 to 12% of the blood resides there, 8 to 11% within the heart. So that's going to be then circulated around to the systemic arteries, the capillaries, where this is where most of the basically the oxygen exchange is going to be occurring. Blood's going to be picking up CO2, dropping off O2 to the tissue. That's where majority of that's occurring there. The large veins, again, these are going to be high capacitance vessels, along with these small veins and venules, are going to be able to pick up majority of the blood. So about 2/3 of it will be sitting there on the venous side, waiting to be circulated. And again, we'll talk about this a little bit later, but when you have kind of this low flow, low pressure system here in the veins, you have the tendency for blood to kind of become more stagnant. So especially like if you're like sitting in a room full of 8 hours straight a day, right? Like blood becomes more stagnant, and then you can see issues with clotting that can occur. So you guys ever heard like a DVT or a deep vein thrombosis? That's where this problem comes about, where you'll find that these big veins that are holding on to a lot of this blood, if it just sits around, doesn't really get moving at all. So for instance, if you're sitting in your seats for 8 hours straight, then your muscles are really moving in order to circulate that blood around. It sits there and it can potentially coagulate. That can be one of the big problems you run into. You hear that a lot with like overseas flights and things like that. Carrie Fisher, right? She came over, and part of that was thought to be due to a deep vein thrombosis that may have broken off and caused a pulmonary embolism secondary to that. There was also a ton of drugs found in her system, so could have also played a role. Who's to say? A medical examiner is to say, but not us. Anyway, so looking at our blood volume, how we're going to be regulating this. So the role of the sympathetic nervous system, it's not simply just looking at, epinephrine, norepi is the only thing kind of regulating blood volume and blood pressure. You're going to find there's lots of other hormones that are going to be involved in the system as well. And also, when we go through, you'll notice there's going to be lots of drug targets. So a lot of the medications that we use to treat hypertension and CHF, you're going to notice are going to be combating certain hormones and certain systems here that we're going to be looking at. So what we can see is that when you have an increased blood volume, so say you have hypervolemia or something where you're not getting rid of enough fluid, you're going to cause increased stretch within the atria. Okay, so more venous return back to the atria, going to cause more stretch in the muscle, and that's going to stimulate those stretch receptors that leads to increased sympathetic stimulation. That's going to lead to that effect on the heart. It's going to lead to decreased stimulation of the kidneys to retain blood volume. Okay, right, because the kidneys are a big place where we regulate how much volume we want to hold on to or how much we want to get rid of. So one of the things you can see released here is going to be ANP, which is going to be atrial natriuretic peptide. We'll show us what that, spell it out for you just in a second. But this is going to be one of the main hormones that gets upregulated or increased release when you have that atrial stretch that occurs there. Also what happens kind of downstream is that the kidney arterioles are going to dilate, which is going to mean that you're going to have increased blood flow that increases urine production that will increase end up decreasing that blood volume. So again, if you have too much that atrial stretch happening there, you're going to end up having kind of downstream effects that occur to where you're going to have increased elimination of fluids from the kidneys. Okay, getting rid of that, you're going to end up decreasing that atrial stretch. It's going to decrease release of that, and now we have again a negative feedback loop, right? Because again, we want to maintain that homeostasis. So one of the things we'll look at when we're talking about the kidneys, and I'm going to try to do something I was trying to not do ever, but I'm going to try to draw. Keep in mind, I am left-handed, and I'm using a mouse with my right hand, so this is not going to be pretty, but I'm going to do my best to kind of show you what we're looking at here. So you guys are familiar with the glomerulus? What is that? Yeah, it's going to be the filtration unit when we get to the kidney. So again, so this is a glomerulus. Okay, this is where blood flow is going to be coming into the kidney. A little arrow here, and then blood coming out, right? This will be the venous side, this will be the arterial side. So one of the things you'll see is that if I were to increase the diameter of those vessels, I'm increasing blood flow into the kidneys, and then I can get rid of more of that fluid. Okay, these are going to term what we call afferent arterioles. It's A-F-F-E-R-E-N-T, and so they play a big role. And when they dilate, they allow for more blood flow to the kidneys, more filtration, more elimination. Right? You have these efferent arterioles. That's E-F-F-E-R-E-N-T. These are also going to be playing a role as well as in regards to when they dilate or when they constrict. But again, here you'll notice that these arteries are going to dilate. That allows for more blood flow to the kidneys, allows for more filtration, elimination in the urine. Okay, so when you drop that blood volume down, that causes more or less stretch in the atria, less stretch in the atria, and that's going to lead to homeostasis again. Now we're back at a normal blood volume. Everything is copacetic, right? Okay, makes sense so far? We're going to look much more into depth in some of these other hormones and get involved with this. But that's essentially what's happening. We'll see what the actual kind of nitty-gritty of it in just a few minutes. So the other kind of flip side of that is going to be with antidiuretic hormone. We mentioned ADH or vasopressin. What does ADH do for us? So hold on to fluid or get rid of fluid. Antidiuretic hormones likes to hold on to fluid, right? So this is going to be kind of the flip process of that, where basically ADH or vasopressin, it gets released from that posterior pituitary, as we remember. Basically, when those osmoreceptors are going to detect that plasma osmolality increasing, right? So as you lose more fluids, as you become fluid depleted, what does your serum osmolality do? As it gets more concentrated, does it go up or down? Should increase, right? So as I get rid of the fluid, I still have all that solute sitting there in the blood. It gets more concentrated, and so the osmolarity actually goes up, right? So as that increases, your posterior pituitary kind of detects that, and it's like, hey, we need to get rid of, or we need to bring in some more fluids in order to dilute out all this solute, right? So that's where ADH gets released. And again, as you, it'll cause your thirst reflex to kick in, right? This one's going to say, hey, I need to drink some water to increase my fluids. What does that do in the kidneys? Do you guys remember? Causes water reabsorption, right? Because it causes those aquaporins to get put into the nephrons. So that way it'll actually absorb more water. Also helps to absorb a little bit more salt in that loop of Henle. We'll talk more about that in detail. But just know that we're trying to retain more water to try to dilute out the blood. Try to get that osmolarity down. So that way it kind of detects, hey, we have enough blood volume around. Osmolarity is looking good. And then ADH secretion should go down. It should kind of finish that negative feedback loop at that point. Okay, so again, that would be an osmoreceptor that gets stimulated when you have low blood volume and high concentration of solutes there. So you can just kind of show you in the picture here. Here's the posterior pituitary releasing the ADH. That's going to increase the permeability of things like the collecting duct in the kidneys to retain more water, right? So water reabsorption helps to dilute out that osmolarity, helps to go down, and that should maintain us at a normal blood osmolarity. We mentioned is around 300 milliosmoles per liter or so. And again, that's going to also, you're going to be drinking more water, hopefully, and hopefully that will dilute things out, and then you're back at baseline. Okay. All right. And of course, you can have cases where this kind of becomes deranged in some instances. So you can have cases where you actually are secreting too much ADH. I think I mentioned that before. We had that syndrome of inappropriate antidiuretic hormone release, or SIADH. That is a common thing we run into in the hospitals for a lot of patients, where they're basically just releasing too much ADH. They're causing them to hold on to too much water. And what does that normally do to the osmolarity, you think? Cause it go down, right? And so you actually can end up getting hyponatremic from that. Your sodium levels can go down too low when you have too much water reabsorption. So that's one of the problems you run into quite often. But basically, when you have back in a normal serum osmolarity, that should cause those osmoreceptors to stop firing. You see less ADH being released, and then you're back at baseline. Okay. So again, when we talk about our stretch receptors in the atrium, we also have what we call the carotid sinus. You guys know where the carotid sinus is? Right along here, right? There's going to be some receptors there that are detecting stretch as well, and that can help to determine blood pressure. And so when those end up getting the stretch receptors in the atria, you end up getting stimulated, it's going to release this atrial natriuretic peptide. And this is, again, natriuretic. Or do you guys know what natriuresis means? Basically means lose sodium, to pee out sodium, essentially, right? So that's where you get the name of that. So atrial natriuretic peptide means you're going to be losing more sodium in the urine, and where salt goes, water follows, right? So when you lose that salt, you're going to lose that water that goes along with it. That helps to reduce that blood volume. So kind of think about like, your A and P being the flip side to ADH essentially. So again, looking at another good picture of the negative feedback loop that gets used here. So for instance, if you have a dehydration or decreased blood volume, that's going to lead to an increase in blood osmolarity. Also, if you have like too much salt ingestion, that can be a problem as well. With our American diets, we typically get more salt than we need, but you're going to see an increase in that blood osmolality. That's going to cause your osmoreceptors in the hypothalamus to increase your thirst reflex. So you're going to have more drinking, hopefully of free water, hopefully not more salty water or anything like that. Your posterior pituitary is going to be releasing more ADH. Going to cause more water retention by the kidneys, and thus your blood volume should be going up, blood osmolality goes down, and that feeds back and drops out your ADH release. Okay, so you guys are pretty familiar with that. So aldosterone also has a big role to play here, and you guys remember where aldosterone comes from? Right, it comes from the adrenal cortex there, and so basically it's a hormone, right? It's very similar to something like cortisol. We mentioned before, they're all in the same kind of hormone category, but this one is going to play a big role in fluid regulation within the body. Now, aldosterone gets secreted by adrenal cortex when you notice that blood volume and the pressure are reduced. Okay, so the body senses low blood pressure is going to release more aldosterone in order to help to bring that pressure back up. And so what it does is it actually helps to stimulate reabsorption of sodium and water in the kidneys. Okay, it's going to do that. It's going to be a big thing. Also, you're going to see a loss of potassium. In order to get that sodium reabsorption, you're going to end up losing potassium. So normally you'll end up seeing, if a patient had hyperaldosteronism, mentioned they can potentially have hypokalemia, right? Because they end up losing a lot of that potassium in the urine there. And so, again, normally what you end up finding is because you're retaining sodium and water to a roughly equal measure, you're going to see that it does not really change the blood osmolality since both of them are being involved there. You'll see that this is mainly going to be regulated by this renin-angiotensin-aldosterone system, or the RAS system, as you may see it being called. And so angiotensin is going to be a really, really important enzyme we're going to be talking about involved in blood pressure regulation. You guys ever heard of ACE inhibitors? That's angiotensin converting enzyme inhibitor, and that has a direct role to play with this angiotensin system here. Okay, basically what ends up happening, and I'm probably going into more detail in this in other slides, but I'll just explain it here, but in the kidneys like to detect blood pressure as well. You guys heard of the juxtaglomerular apparatus before? We'll talk about that when we get to the nephro section, but essentially they're dedicated cells that determine what the pressure of the blood flow in the kidneys is. Okay, so I mentioned that the glomeruli, if it detects too low a pressure, it says, hey, we need to increase blood volume, we need to do something to get the pressure up around here. So what it actually ends up doing is releasing this hormone called renin. Renin is then going to cause this reaction where this kind of precursor molecule called angiotensinogen gets converted over to angiotensin 1. And then eventually you're going to have this angiotensin converting enzyme. You're going to find this both in the lung and also the capillaries, converts it over to angiotensin 2. And so the angiotensin 2 is kind of the major business molecule of the RAS system, where you're going to see that it increases vasoconstriction. Right, so that's one way it helps to regulate pressure. And then it also is going to help to increase expression of aldosterone from that adrenal cortex. So when you have more aldosterone coming out here, you're going to have more sodium and water reabsorption, which will also increase blood volume and should increase blood pressure as well. Okay, so it's one of the kind of major systems you're going to see being involved here. And you have a lot of patients of kind of chronic hypertension who are usually excreting way too much renin. They're usually going to have way too much aldosterone. And so a lot of the drugs that we use directly affect the system in order to inhibit it at several different steps. So again, blood pressure is low, cells in the kidneys, those juxtaglomerular cells, are going to secrete that renin enzyme. Angiotensinogen gets converted over to angiotensin 2, and this is the major one we're really concerned with, is increasing blood pressure. But it should cause aldosterone to go up. Should also, because we are detecting low blood pressure, it also should help to increase secretion of ADH as well. So again, another stimulus to increase ADH secretion that will hold on to more water in order to increase blood volume and increase blood pressure. You're also going to see some other big effects of angiotensin 2, especially on the actual cardiac cells themselves. And so this is one of the big problems you run into over time, is that you guys heard of the term remodeling of the ventricles, right? Essentially what happens is, as the heart is having to beat against this high blood pressure over a long period of time, and it starts to adapt, just like any muscle does, right? So if I lift heavy weights every single day, what should my muscles do? Should hypertrophy. They should get bigger, right? And if you're looking at the flexibility of like a bodybuilder, how flexible do you think they are? They're like this. They can't really reach around. I've heard some people can't even have trouble going to the bathroom because they have such little flexibility. The same thing happens to the heart, essentially, where it's not able to really stretch very well. It's not very compliant. And so that remodeling process that occurs there leads eventually to kind of irreversible damage to the heart where you're not really able to beat all that efficiently. So this is one of the big things we look at inhibiting when we're treating a patient with high blood pressure, because we want to prevent that remodeling from occurring. Same thing after like a myocardial infarction. So this will come up again and again, very, very prominent, especially like in pharmacology. We'll talk about it a lot. CMS, you guys will cover this ad nauseum. So it's important to get a good understanding of it right here. So again, when the kidneys are detecting low blood pressure or low flow to the kidneys, that directional glomerular apparatus is going to increase renin release. That should be eventually leading over to angiotensin II being made. I mentioned the ACE enzyme. This is one of the big drug targets we'll talk about when we get to pharm. That angiotensin II causes aldosterone to be released, causes vasoconstriction of the arterioles, all of which should increase blood volume and blood pressure. And that feeds back. And once the kidneys detect now that they have enough pressure, then they can shut off that renin release. Okay. So again, a negative feedback loop here in order to help regulate our blood pressure, regulate our blood volume effectively. So again, angiotensin II should be causing these vasoconstriction of small arteries and arterioles. So your total peripheral resistance should increase, right? So again, increased peripheral resistance should do what to our stroke volume? Should decrease it if it was not combated by increasing inotropy of the heart. You'll also see it stimulate that third center in the hypothalamus. So again, you're going to say, hey, I don't have enough pressure. Let's drink some more water to try to increase blood volume. And then you're going to stimulate that adrenal cortex to secrete aldosterone, which again is going to hold on to salt and water in pretty equal amounts. So you should see no change in osmolality, but it should have an increase in blood volume. Okay. Again, just another slide kind of showing you some of the different processes that are happening here. So again, angiotensinogen gets released by the liver here, gets affected by renin, which converts that over to angiotensin I, over to angiotensin II eventually. You can sometimes see this happening up in the lungs, but most of that in the vasculature, you'll see this conversion that actually occurs here. Angiotensin II, again, is going to help to increase things like sympathetic activity. So you can see an increased release of things like epinephrine, norepinephrine when this occurs. You're going to cause more salt and water reabsorption. Again, a lot of this happens through aldosterone, but can also happen through somewhat through angiotensin II as well. You're going to have, again, this is a good picture kind of showing you how you're going to have more sodium, chloride, and water reuptake, but then you're losing potassium. Right, so kind of long-standing hypokalemia can be another problem you run into with some of these patients have kind of a high angiotensin II expressing kind of state. You're also going to see the arteries are going to be vasoconstricting, so that should cause an increase in blood pressure as well. And then also ADH secretion from the posterior pituitary should be increased, all of which is going to lead to more ADH being released, leading to more water reabsorption, plus bigger blood volume, bigger blood pressure. Okay. And once the kidneys start to detect that increase in pressure, then they can feed back and say, hey, we're good here, we don't need any more renin being released, and it will kind of shut down all of these systems here to some extent. Okay, so we mentioned those are good for increasing blood pressure, but on the flip side of that, you have your regulation by the atrial natriuretic peptide, or that ANP. You'll also hear about brain natriuretic peptide. It's going to be another big one when we talk about CHF patients. That should be a lab that you're going to measure. So that kind of helps along the same process here, but we'll focus on ANP for this period. Basic ANP gets expressed by the atria when they detect further stretch. So if your end-diastolic volume was high, if you had a high preload, that should be stretching those atria in order to release more of this ANP. And basically what that does is help to promote sodium and water excretion in the kidneys. Right, so now we want to get rid of that pressure. So we're going to end up increasing excretion of water within the kidneys, and it should do most of that by increasing that blood volume to the kidneys itself, right? So it causes that vasodilation in that afferent arteriole. Open that up, allow for more blood flow in, more of it gets filtered, you lose more water to the kidneys. Also going to inhibit ADH secretion, so again that also helps with losing that blood volume, getting rid of some of those extra fluids, and will be an antagonist or inhibits aldosterone. So the ANP is going to be increased release when you have too much blood volume around, too high blood pressure, helps to decrease the renin system, the aldosterone system, also helps to block ADH as well. Okay, so kind of two sides of a coin to think about how to regulate blood volume, blood pressure. All right, everyone still with me? Any questions so far? Pretty straightforward for the most part. Okay, just another good picture kind of showing you how the system is going to be working. So when you have increased venous return, increased blood volume, So say a patient had too much fluid on the system, they were drinking too much water or something like that. Increased venous return will stretch those atria. That'll increase release of the atrial natriuretic peptide, so we're excreting more water and sodium. You're also going to be affecting the vagus nerves here to where you can decrease antidiuretic hormone. That'll also lead to decreased water reabsorption. Get rid of that in the urine. As urine volume increases, blood volume is going to decrease, and thus you have that negative feedback loop being established. So for instance, if I were to ask like a test question, I could say something like, which one of these hormones would be in high expression if you had a patient with high venous return and high end-diastolic volume? So okay, which one would be activated by having too much blood volume around? You would say atrial natriuretic peptide. Absolutely, you guys are all right. Good job. Okay, once you go through it a few times, you'll kind of understand and think about those different patient scenarios. Like, okay, I have a guy who has way too high blood pressure. That means he has too much blood volume. He has too much atrial stretching. What gets activated by that? What are the compensatory mechanisms that occur to try to get that guy back to, or guy or girl, back to homeostasis, right? Because again, your body likes to maintain normal, your blood pressure within normal ranges. Again, over time, you can see that kind of shift, but we like to maintain homeostasis as best we can. Okay, next we'll look at vascular resistance to blood flow. How can we affect that? Because again, we mentioned increased vascular resistance. It means we have a higher TPR. It means you're going to cause our stroke volume to go down, and thus potentially cardiac output to go down as well. So again, where do you think the highest pressure in this whole system is going to be at any given time? Yes, the left ventricle, probably followed by the aorta. You're going to see typically there's a higher pressure system. As it gets over into the capillaries, we see the gas exchange actually starting to occur. Gets back into the venous system. Typically pressure should be a lot lower over here, but at all times that dilation or constriction of those vessels is being maintained by several different systems, as we're going to look at when we get through here. So again, if I were to say like increase the pressure on this side, what do you think that does to venous return? So increase the pressure here. You should be actually, especially if you think about, moving our muscles around, kind of pumping the blood as well. That should increase venous return, right? So that can be one of the things we can see where if I cause dilation of these vessels, if I lower that pressure, they can hold more blood, right? And that does what to venous return at that point? Should lower it, right? So we can see how we can affect afterload and preload, both by changing the capacitance for these vessels, right? If I were to dilate these vessels here, what do you think that does to the afterload? Should decrease it, right? So again, when we were talking about our different like medications and how they're going to be affecting the system, typically by lowering the pressure, you're going to end up lowering afterload and preload, depending on which kind of vessels you're talking about. We'll get into more detail on that as we go forward. Okay, so looking at our extrinsic regulation of blood flow. So again, autonomic, we have a lot of autonomic control of blood pressure and also the endocrine control as well. And again, which one do you think is more quick? Autonomic should be a lot quicker than your endocrine system for the most part, right? Obviously, things like epinephrine get released from the adrenal glands, which still is considered an endocrine system. But for the most part, autonomic control should be a little bit faster than your endocrine control. So one of the big things we can see from the sympathetic nervous system is going to be release of norepinephrine. This can help to control vascular resistance on the blood flow by causing vasoconstriction. So again, these catecholamines, things like norepinephrine, epinephrine, these are going to be vasoconstrictive in nature for the most part. This is mainly going to be through, and there's a table later which will show you some of these different receptors, but alpha adrenergic receptors. Okay, so when you activate alpha-1 receptors on the blood vessels, that typically causes vasoconstriction. Okay, increases your pressure. You can also see this in places like the skin, the GI sphincters, urinary sphincters, GI secretions can all be affected by this. And so this is really important because when you look at patients, who are like in a really high stress kind of state, you can end up seeing kind of other problems that can pop up from this. So for instance, if I had a patient who was in a kind of a chronically high stress state, I'm releasing a lot of my sympathetic nervous system neurotransmitters like norepinephrine and epinephrine. Sure, that's good because I can regulate blood pressure effectively, but if I increase my GI secretions when I'm in a case where I don't really need to digest food because I'm in a really high stress state, that can end up leading to things like gastric ulcers that can form because you're releasing too many acids into the stomach and they can burn a hole through them. So that's a problem we run into a lot with our critical care patients, is the fact that they get into a very high kind of stress state and end up seeing kind of normal barriers of things like the stomach break down, and they can having ulcers that can form from that. So again, it'd be nice if we have a little bit better specificity, but sometimes we lose that when patients are really, really sick. Yep. So you mentioned that the sympathetic nervous system you thought were regulated through beta receptors. There's going to be different subtypes of receptors, right? So just like we mentioned with like G proteins, there's how there's like a ton of different G proteins are out there. There's lots of different receptors, and their expression is going to be based on the tissue that you're in. So we mentioned things like what receptors are responsible for increasing chronotropy in the heart via the sympathetic nervous system. You guys remember? Alpha, beta, gamma, delta. It's beta 1, right? So we mentioned that beta 1 receptors are really, really important, and you see it. This is going to be for the blood vessels, but remember that there's a picture back in one of the last lectures where you can see that on the cardiac muscles, increasing that beta effect is going to be leading to increased chronotropy, or increased speed of the heart rate. But you'll notice that you can have different tissues express different adrenergic receptors. And so in the blood vessels, you see a lot of alpha receptors. They're going to be expressed here. Alpha 1 is going to be one of your primary ones. They kind of regulate this. So by increasing alpha 1 stimulation, that causes a contraction of that smooth muscle, the vasculature, and that increases your blood pressure. So it just depends on where you're looking at, what tissue you're looking at. It can express different receptors that will have different effects. We'll get into all of that in much more detail as we go a little bit further into this lecture. But again, mainly norepinephrine to some degree is going to be released from those sympathetic nerves to cause increased stimulation. Specifically, the alpha receptors. Alpha 1 is going to be one of the big ones to talk about here. And on the flip side of that, you're going to have release of acetylcholine from the parasympathetic nerves, mainly affecting the muscarinic receptors. Right. So when you're thinking about parasympathetic nervous system and acetylcholine, you're thinking about muscarinic receptors. Okay, nicotinic receptors are really important for like neuromuscular transmission, important for synaptic messaging between neurons. But for the actual parasympathetic nervous system, the end point is that they're releasing acetylcholine onto muscarinic receptors. Okay, we'll look at the table. We'll have some more details on that in a little bit. But when you have release of this, this is also going to have a little bit of control in vascular resistance and blood flow. But you can also see things like vasodilation that will cause, things like your skeletal muscle to vasodilate. It will cause the sweat glands to also be affected as well. So we'll kind of see how those are going to kind of shift between one another, because it's always going to be a balance between sympathetic and parasympathetic, and how those effects will kind of change. So when you're looking at your sympathetic nerves, again, you have a lot of this being released from the adrenal medulla, having epinephrine that will stimulate beta adrenergic receptors. And so specifically here, these are going to be beta 2 receptors we're going to talk about. So when you're looking at the vascular smooth muscle, beta 2 activation causes relaxation, right? And so we mentioned, you guys remember that drug albuterol I mentioned before? They're used to treat asthma, right? Because when you have asthma, you're having your bronchial smooth muscle constricting too much, and it's impeding airflow. Versus when I give a beta 2 agonist, like albuterol, that helps to relax that smooth muscle. It will dilate and allow for better airflow. Same thing happens to the blood vessels. They all have beta 2 receptors on them that, when activated, will cause vasodilation to occur, right? So that can actually lower your blood pressure. And so depending on where you're at, if you're in a fight or flight kind of scenario, you may need more blood flow to certain areas of the body and less blood flow to others. So for instance, if you're being chased by a bear, do you need to worry about your stomach getting a ton of blood flow? Probably not. I don't really care about digesting that sandwich I had. I can throw that up later, right? Which again is when you go do something strenuous after eating, you typically end up throwing up, right? Because a lot of that blood flow is being shunted away from the GI tract. On the other hand, if I'm trying to run away from something, muscle blood flow should increase, right? Because I want to get more blood to the muscle, I want to deliver more oxygen, allow them to work a little bit better. So you're going to see how in different situations and different tissues that blood flow can be affected a little bit differently based on the situation. Does that make sense so far? Okay. Wish I had a really good, saw a really good case report. You guys ever heard of this? So I talked about albuterol being a beta 2 agonist, and usually you inhale that for control of asthma attacks and things like that. You guys ever heard of a drug called clenbuterol? Sometimes it's abused by bodybuilders, and so it also activates these beta 2 receptors. It's also thought to help with like lipolysis and actually break down fat. So sometimes bodybuilders use it for cutting fat. But these 2 guys, I guess, had made their own. They found a recipe on Google, made their own, and they end up having extreme activation of these beta 2 receptors on the blood vessels. And we said that's going to cause vasodilation. So what do you think the blood pressure did? Bottomed out. So blood pressure just like bottomed out completely. They get really, really dizzy. They get hypotensive. They're just kind of like completely out of it. Get brought into the ER, and they're like, "What the heck's going on here?" Figured out what it was and said, "Okay, well, obviously it's due to that beta 2 receptor activation, causing this vasodilation." Okay.
So epinephrine is beta 2 in the blood vessels, and norepinephrine is alpha.
That's a good question. So, you said that epinephrine is maybe beta 2 on the blood vessels, like norepi is going to be alpha. You're going to find that with those catecholamines, they have a little bit of different balance between the receptors that they're hitting. So for instance, this is kind of how I talk, because we use a lot of these drugs to increase blood pressure. So if any of you guys have ever seen like dopamine or epinephrine or norepinephrine given as drugs exogenously, it's usually to increase blood pressure. And so there's a little bit of different a little different flavor, I say, to each of them, where you can see that like with your norepi, that really affects a lot of alpha receptors. So and it doesn't really affect the heart quite so much. So because of that, you see some increase in heart rate, but you see a lot of increase in that peripheral squeeze, and you get a higher blood pressure. Versus something like epinephrine is a little bit more balanced. So you will see some increase in blood pressure because it activates the alpha-1 to some degree, but also affects those beta receptors in the heart. So you actually see increased heart rate as well. So it depends, is basically what the answer is.
So like with epinephrine, you dilate blood vessels, you're saying it's decreasing, but also at the same time it's increasing contractility.
Well, when you're giving epinephrine, it's going to be decreasing blood flow to certain areas and increasing blood flow to other areas, right? Because preferentially, if you're like, say, like in a trauma situation, you're losing a ton of blood flow or losing a ton of blood, right? Where does your body want to send blood to? The brain and the heart, right? So we got to keep those two organs going at the minimum, right, to sustain life. And so you're going to see that the catecholamines like epinephrine will be released in order to make sure that blood flow is being maintained that way. So you will see that, you know, coronary vessels may dilate because you want to make sure you're getting lots of blood flow to, oxygen to the heart tissue, right? You may see that the vessels going to the GI tract are all very much constricted because we don't really care about that blood flow to that tissue right now, right? So again, it depends on the tissue, where you're looking at what the situation is to see how that's going to be affected. But in general, just know that alpha-1 receptors, when they get activated, cause vasoconstriction, right? It should increase blood pressure. But your beta-2 receptors, when they get activated, should cause vasodilation. And we said beta-1 receptors are really good for doing what? Yeah, increasing heart rate. Okay, so beta-1 receptors are really good for increasing heart rate. That's simplifying a little bit, but again, for your purposes, when you're out there and you're like, okay, I need to increase this guy's blood pressure. What receptors do I want to hit? Okay, what drug can I use to do that? Or what can I do to affect that? Those are the kind of things you're going to want to have, you know, those concepts solidified in your mind when you're actually dealing with a patient. Okay. Okay. I think we'll give you guys a 10-minute break now. We'll come back and then continue on with our talk of blood pressure. No pressure, but come back. All right, let's keep going. I just mentioned that my ADH was being suppressed from all the water I was drinking and had to get rid of some blood volume. So see how physiology comes back at all times in life. It's a gross way of saying I went to the bathroom. All right, anyway, looking at some of our autonomic functions, we can see where different tissues you'll have different expression of various adrenergic type of receptors. You can see we have the parasympathetic nervous system listed here as well, where you can see some of our muscarinic receptors. Mentioned in the eye, we just got done talking about the eye, right? Remember the radial muscles that will contract and dilate the pupil, right? When you're in a you know, either in a low light situation, or if you're in a case where you're like having your you know, fight or flight response, you're going to cause pupils to dilate. That's mainly going to be regulated through the alpha-1 receptors, right? So this is also why I can give a drug called phenylephrine. It's actually a pure alpha-1 agonist. I can give that to a patient, and that will cause them to dilate. So if I'm doing a specific eye exam, or if I need to do it for whatever purposes, you know, for like ocular surgery or something like that, I can give a drug that specifically hits that receptor, activates it, and then causes that dilation to occur. Alternatively, I can affect this muscarinic receptor as well. So if you guys heard the drug atropine, I think I mentioned it before, but that's an anti-muscarinic. So it actually blocks this muscarinic receptor here, and actually will lead to, instead of, usually those muscles will contract when they're activated by acetylcholine and constrict that pupil, causing, what do you guys call that? You have pupillary constriction? Meiosis, right? So instead of causing meiosis, if I can block that receptor, it will cause mydriasis instead. Right? So that's another common drug that we'll see being used by ophthalmology to do their exams. Then looking at the side of the heart, if we're looking at, and again, keep, oh yes ma'am. Yeah, because essentially if I block the effects of acetylcholine on this receptor, this muscarinic receptor, it allows those, because again, you know, at baseline, you're always going to have some degree of contraction of all those muscles. It's going to relax those muscles though, because it's not going to have that acetylcholine effect there. So basically it'll cause, instead of contracting, they'll relax and allow for the pupil to kind of open up. So then you have kind of this unopposed sympathetic effect, where now only the alpha receptors are kind of regulating that contraction there, and that's why you can see the pupils dilate. Yep. So similarly on the heart, you're going to have antagonistic effects between the sympathetic and parasympathetic nervous system. We mentioned that primarily the sympathetic nervous system affects both chronotropy, or the speed of the heart, especially through these pacemaker cells like the SA node, is going to be through increasing heart rate, and it's primarily going to be through the beta-1 receptors. Okay, so when we talk about beta blockers, we like things that block beta-1 specifically because that's going to be primarily what we see on the heart. For contractility, you also see beta-1 has a good effect on increasing contractility, so increasing that squeeze, or the force of contraction, to allow for us to spit out more blood or increase our stroke volume. On the flip side of that, you can have the muscarinic receptor. Primarily, you're going to see it more affect heart rate than anything, so things like acetylcholine or things that block acetylcholine receptors at that muscarinic receptor, primarily going to be related to chronotropy, decreasing heart rate, but you're going to find that they don't really have as much of an effect on the contractility. So much kind of minor effect here, but again, all through the muscarinic receptors. And then looking at, again, sympathetic on this side, parasympathetic here on the right. Looking at the vascular smooth muscle, you can see here, like, you know, in skin and splanchnic vessels. Again, splanchnic vessels mean like things like the GI tract and areas like that. Again, when you're in a high stress state, you're in a fight or flight state, you don't really need a ton of blood flow going to places like the viscera as much as you do for things like your skeletal muscle. So you can find that it will contract or vasoconstrict, primarily going to be through these alpha receptors, right? Again, yeah, things like norepinephrine and epi, like they're not going to have 100% specificity to these receptors, so you still get a little bit of beta activation, but primarily alpha is the big thing causing that vasoconstriction to occur there. When you're looking at the skeletal smooth muscle, though, and you're in the same kind of high stress state, you're going to cause vasodilation because you want to have that blood flow to the muscles. You want to be able to deliver more oxygen to the tissue and get rid of all that waste products. That's primarily going to be through beta-2. Okay, there's a little bit of minor effect here with muscarinic relaxation. Again, muscarinic drugs don't really cause a ton of effects on blood pressure. It may see a little bit of relaxation, a little bit of lowering of blood pressure. For the most part, though, it's going to be primarily related through the sympathetic nervous system. And then looking at our bronchial smooth muscle, you can see here that we can give beta-2 agonists. Typically, beta-2 is going to be more vasodilatory. It's going to be more causing smooth muscle relaxation. We like this because it causes bronchodilation, right? It's relaxing of the bronchial smooth muscle, allows for better airflow. Okay. Now, in some cases, we can actually induce bronchoconstriction. So, if you were to have a case where you had a patient having overly active acetylcholine working on these muscarinic receptors, you can have contraction cause bronchoconstriction. And so we can actually do that therapeutically when we're testing patients to see if they have asthma. We can actually give them a drug that will activate these muscarinic receptors, and it will cause that bronchoconstriction. And if they have kind of overly excessive bronchoconstriction, that's pretty indicative that yes, they do have asthma. And then we would give them a drug to block that, or we typically give them a smooth muscle relaxer, and then say, okay, you have asthma now. That's one of the things we can kind of do. Sounds kind of mean, but it's good for kind of provocative kind of tests where we can determine these sort of things. Again, looking at the GI tract, looking at the smooth muscle, again, looking at the, you have relaxation here of the smooth muscle on the walls here through the beta-2 agonism. The sphincters typically get more constricted when you have alpha-1 activation here. Notice how the muscarinic receptors are going to have conflicting effects. They're going to have kind of antagonistic effects to them for the most part, because again, the parasympathetic nervous system is all rest and digest. It's going to be more stimulatory there. So that's primarily it for the most part. Again, realize talk about an alpha receptor and what that does on the blood vessels. Know what that does. If I say beta-2 or beta-1, be able to differentiate kind of what their main functions are going to be within the body. Okay. I'm probably not going to test so much on the GI tract stuff, mainly because we're talking primarily about the cardiovascular system. So focus more on that aspect of it. We'll talk GI later on in the class. Okay. Okay, so kind of looking at several different substances and systems and how they're going to be affecting blood pressure. This is a good table to have a good understanding of, because you need to know, like, a patient has too much sympathetic activation. What does that mean? What is that going to do to their body? How can we combat that, right? How can we treat that? So again, looking at the sympathetic nerves, we're going to have our alpha adrenergic receptors. These are primarily going to be for vasoconstriction, increasing blood pressure. Beta adrenergic, primarily going to be related to vasodilation. Right, the blood vessels. It's going to be beta-1 receptors, though, having more kind of positive chronotropic effects on the heart, positive contractility. And then cholinergic, again, kind of minor effects, but a little bit more on the vasodilation side, so not nearly as important as the sympathetic for blood vessel control. Looking at parasympathetic nerves, again, angiotensin 2, ADH, these are all going to be vasoconstrictive. So when your body's detecting too low a blood pressure or too low a blood volume, it's going to respond by increasing these systems here. We're going to have more angiotensin 2, more ADH being released there to cause vasoconstriction. Okay. Now, you have things like histamine and bradykinins. These are oftentimes going to be byproducts of allergic reactions. So we'll look more at that when we get to the immune system in the next section. But things like histamine are a really big one that causes vasodilation. So if I were to have a patient who had an anaphylactic reaction, say to peanuts, they come in, they're releasing a ton of histamine. Oftentimes their blood pressure is very low or high, do you think? Very low, because a lot of histamine, they're causing vasodilation. So again, that's going to be one of those things where I can give them a drug to reverse that. Do you guys know what it is? Epinephrine. We can actually give them epinephrine exogenously to try to stimulate those alpha receptors to bring their blood pressure back up. Basically, we're using it to combat the histamine effects, which are vasodilatory. Okay. Bradykinins, we'll talk more about this when we get to talking about the, some of the side effects of ACE inhibitor drugs and things like that, but that also can be increased releasing things like allergic reactions and whatnot. And then prostaglandins, we mentioned prostaglandins come from where? Yeah, the arachidonic acid pathway, right? So we liberate some of those phospholipids from the cell layer. We can use arachidonic acid as a precursor to make a lot of these prostaglandins. You're going to find that some of them are going to be vasoconstrictive and some of them are going to be vasodilatory. Now, it's confusing, but it's depending on which one you're actually dealing with. So for instance, when you have a drug like prostacyclin or PGI2, that's going to be more of a vasodilator. Okay, it's going to relax the smooth muscle, offer better blood flow. Versus things like thromboxane A2, which is going to be more of a vasoconstrictor. So it can lead to higher blood pressure. It can lead to decreased blood flow to certain areas. And so we'll talk more about those in detail as we get into specific sections. But just know that prostaglandins can be kind of a mixed bag. Some will be vasodilatory. Some are going to be vasoconstrictive. And you guys remember you mentioned that when you're trying to activate platelets, you guys remember any of the prostaglandins that are involved with that? Yeah, thromboxane A2 is one of the things we use to help to regulate activation of those platelets, right? And also, when you have vascular injury, what do you want to do to blood flow to that area? You would typically want to decrease it. You don't want to bleed out. So thromboxane A2 can help with that. On the other hand, though, if you don't have any vascular injury, you want to keep the blood vessels flowing nicely, you release what? Prostacyclin or PGI2, and that helps to keep things from helps keep things dilated appropriately and allow that blood to flow more naturally. Okay, so again, some of these things are already starting to come back and see where they can be involved in several different processes. Okay, just in general, vasoconstrictive, think about alpha adrenergic activation, think about angiotensin 2, ADH, thromboxane A2, these are mainly going to be vasoconstrictive in nature, versus your beta adrenergic via beta 2 receptors, more vasodilatory, cholinergic receptors, parasympathetic nerves, which kind of goes in line with the cholinergic receptors there, histamine, bradykinins, prostacyclin, all going to be vasodilatory. Okay. So if I said, I gave someone a drug that blocked the effects of histamine, what should that do to your blood pressure? Should increase, right? And we see this a lot. A popular drug to give for patients in pain is morphine. Morphine is actually a drug that causes a significant amount of histamine release for some patients, and so you can actually see them becoming hypotensive after getting a dose. And that's one of the things where, like when you're working up like an intensive care patient, you're like, okay, why is their blood pressure dropping? Is it one of the medications? Oftentimes you can link it back to morphine. We can give them antihistamines, things to block the activity of histamine, and actually will fix the problem in a lot of cases. Okay, so you're going to start to see where there's a lot of clinical applications for kind of mucking around with these systems here. All right, so looking at blood flow to the heart and the skeletal muscles, how do we regulate that? So here we have our coronary arteries. We like to keep these nice and patent and flowing. Oftentimes, this can become a problem, and if you block any of these vessels, what happens? No blood flow, no tissue oxygenation, MI, right? That's no good. So we want to keep these nice and open. We want to keep them flowing nice and well. And again, remember how our EKG kind of lined up with the different precordial leads when we're talking about those different V leads, how those are able to kind of wrap around the heart to kind of look both anteriorly and laterally as well, to make sure that we can see, if an injury has occurred, where those changes are occurring at. We can see kind of which vessel, and so a lot of times you can diagnose which vessel has been blocked based on the EKG changes, right? So something like, this left circumflex branch that gets blocked is going to look different on the EKG via those precordial leads than it would for like an anterior descending branch lead would, okay? Based on those changes, a lot of times they can say, okay, well, I think it's going to be these vessels that are being affected here, and then when they go in for their catheterization, they actually can go in and bust those clots via catheter. Like they can have ahead of time where to go to, essentially, right? So that can be very useful there. But again, how do we maintain these blood flow through these arteries? I'll show you some of the mechanisms that we can use to help with that. So one of the things you'll see is this nitric oxide synthase, or NOS. It's not what you put in your car, right? No. You have nitric oxide, and this is going to be really, really important for helping to maintain vasodilation, right? So this helps to maintain vasodilation, smooth muscle relaxation, allows for better blood flow to a lot of the vessels. And we mentioned, you guys remember the drug that I mentioned before that can be useful through this pathway? It's actually nitroglycerin, right? So when you give nitroglycerin to a patient who has chest pain is usually indicative of what? Usually myocardial ischemia. We're not getting good blood flow or good oxygen delivery to the heart, so your heart starts to hurt because of that. And so when you have that angina or that chest pain, we can give you a drug called nitroglycerin, and that's going to work by donating to this nitric oxide pool and allow for you to cause that dilation to occur. And so that's, you see smooth muscle relaxation, your coronary vessels open up, allow for better blood flow. Now you're delivering more tissue, oxygen to the tissue. Now all of a sudden the pain goes away. So that's one of the very common drugs we'll give when patients are complaining of chest pain because of the vasodilatory nature here. But it is working through increasing levels of cyclic GMP. So typically when you increase cyclic GMP, that's going to have vasodilatory effects on that smooth muscle there in the vasculature for the most part. So again, you have decreased compression of the coronary arteries. It allows for, and basically you can see the way that the blood flow to the coronaries is going to work is that you have decreased compression of the coronary arteries during systole, and that actually allows for, occurs due to that lower cardiac rate there. So, but again, cyclic GMP stimulates this nitric oxide pathway, and you're going to end up seeing dilation occur here. Okay, this is a good table kind of showing you the changes in blood flow to the body based on if you're at rest or in exercising kind of state. So again, here's kind of the heavy exercise state. You can notice here your total cardiac output, maybe say 25 liters per minute, looking at where that gets divided up into. And so you notice where's the majority of the blood going to. Going over the muscles here, about 80–85% in here gets shunted over to the muscles. You notice here that things like the GI tract is going to take a hit here. Things like the kidneys and the brain, not nearly as a high proportion here as you would be if you were in a kind of more resting state. So again, when you're looking at the resting state here, notice the cardiac output is going to be a lot lower, say maybe 5 liters per minute. A higher proportion of that blood is going to be going to places like the GI tract, to the kidneys, the brain. Relatively small amounts going to be going to the blood, to the muscles, because you're not really working them that hard at that moment. Just realizing a lot of this is being regulated through things like your adrenergic nervous system or the cholinergic nervous system, right? Okay. So you're looking at cardiac output should be going up during exercise, and a lot of that's related not only to the increase in stroke volume, but it also goes up when you're exercising. Should be the heart rate as well, right? And we said cardiac output is a product of heart rate plus your stroke volume. So both of those will end up increasing during exercise. And cardiac rates are going to typically be going up to that sympathetic nervous system activity, typically decrease activity of that vagus nerve, right? And vagus nerve is nerve number 10, right? So you see less acetylcholine effect on those muscarinic receptors. Heart rate should be going up for the most part. Stroke volume should be increased. You'll notice that total peripheral resistance typically is going to be decreased. So you're going to notice you end up having some vasodilation of the arterioles and the skeletal muscle, so that way you get better blood flow going to those muscles there. Okay. Arterial pressure should be increased during exercise, and again, a lot of that is related back to the sympathetic nervous system activating those alpha receptors. So again, we can shunt blood flow around where we need to, but in general, arterial pressure is going to increase when you are in a heavy exercise kind of state. And now, in diastolic volume, now why does this not change? So we said our arterial pressure is going to be increased, so total peripheral resistance to some areas is going to be decreased, but arterial pressure, so the pressure that the heart's pumping against, is going to be increased here. But how come in diastolic volume does not change? So we have better venous return coming in, right? So our in diastolic volume is going to I'm sorry, you're right. Yeah. So basically, by increasing the heart rate, we're still sending out the same amount of blood here. So our end-diastolic volume is going to remain unchanged essentially. So notice how the system's kind of compensating for itself. So even though we may be getting more venous return, in general, our heart's being faster, so that for each pump, essentially the end-diastolic volume does not really change at all. Okay, does that make sense? All right. So again, blood flow to the heart and muscle should be increased because again, it's heavy exercise, fight or flight kind of response. Visceral organs should be decreased for the most part. So things like your digestive tract, liver, all should be decreased for the most part. Blood flow to the skin is going to be increased. Why do we increase blood flow to the skin? So that's for thermoregulation. We get rid of heat, right? So again, when you are exercising, you get very hot. You need to get rid of that heat. A lot of that is related, is done through sweating, right? And so a lot of heat gets taken up to the capillaries within the epidermis, and then we can dissipate that off by evaporative cooling, essentially. We have that all that sweat kind of evaporate off of us. And then blood flow to the brain also should remain unchanged, because again, we want to make sure that we always have good blood flow going to the brain. You don't want to like go run a marathon and then all of a sudden your IQ points drop pretty significantly, right? Probably want to maintain the same kind of brain function whether you're working out or not. Okay, so you can go a little bit further into blood pressure. So looking at the arterial versus the venous system, we already said that the venous system is typically going to be a lot more low pressure than you would see with the arterial system for the most part. And you kind of see how this is going to change. Pressure here on the y-axis, volume on the x-axis. We mentioned that a lot of blood volume is going to be maintained within the venous system, about 2/3 of it for the most part. And then you can kind of notice here how things like normal volume, how this can change based on if I decrease blood volume, how it's going to alter it. Usually the arterial system should stay around the same volume for the most part, right? It's really the venous system that can take a hit if you end up decreasing blood volume for the most part. And then with sympathetic stimulation, you should see increases when you have increased adrenergic receptor activation. You should see that increase in that pressure there. Okay. So, and you kind of see here, looking at the arterial versus the venous side, you can notice the area where basically the largest amount of kind of exchange here is going to be happening during the capillaries. It's kind of where you have the largest volume for this to occur, largest surface area essentially for the gas exchange to happen. Again, venous side is going to be holding on to more fluid, but the pressure is definitely going to be the highest on the arterial side, and this is what's kind of forcing everything through all the way to the end. Okay, so you get a higher pressure side on the arterial than we see on the venous. Okay, so again, you're going to see pressure difference between the arteries and the veins. Typically higher in the arteries. Again, where's the highest pressure going to be typically? The left ventricle, the aorta, typically going to have the highest pressures in those cases. You can see the pressure difference in the venous system. Highest pressure is going to be in the venules versus the lowest pressure in the vena cava going into the right atrium, right? So right after you end up leaving the capillaries, it's probably the highest pressure in the venous system versus all the way when it gets back through the inferior and superior vena cava back into the right atrium. Okay. Highest pressure on the left ventricle side is going to be the aorta essentially, lowest in the vena cava at the right atrium. Now, do our blood vessels always maintain the same pressure at all times? Constantly changing, right? Every time you have a heartbeat, you should have a change in pressure in your vessels, right? So you can kind of see this looking at the changes in pressure here in the left ventricle. Notice how it gets very, very low pressure, and that's important because why? During diastole, you want to have really, really low pressure because that does what? Opens up that mitral valve, allows for gravity to force blood from the atrium into the ventricle, right? So you want to have really low pressure to allow that to occur naturally, okay? If it stayed high all the time, you would never have that mitral valve open up. You would never have blood flow coming from the atrium to the ventricle. You'd be dead. You don't want that. So, though once it's out into the actual arteries, you're going to notice that it's going to have kind of a baseline pressure. So what would you call this pressure here? Systolic or diastolic pressure? It'd be your diastolic pressure, right? Because that should typically be lower. When you have the heart beating, that's going to cause a sudden surge in pressure. That should be your systolic blood pressure. So you notice here how it's going to have a pulsatile nature to it, and that's related back to the fact that it's responding to the heart actually beating, right? So when you're measuring blood pressure, have you guys done that yet in labs? All right, so you notice how you're going to hear the pulsatile nature of it is related back to the flux between high to low pressure there. As you get to smaller vessels, you're going to start to lose more in that, and eventually as you get to very low pressure systems like the venules and large veins, again, these are all capacitance vessels. They want to be low pressure so that way they can hold on to a lot of blood flow at any given time. Kind of a similar picture, kind of showing you the same thing we were looking at before. Again, you'll still get that pulsatile nature in the right ventricles because, again, you're still getting that pump at that point, but still much lower pressure system than you would see in the left side of the heart, as you see over here. Okay. All right, so auscultating the blood pressure. What's the thing we wrap around your arm called? Sphygmomanometer, another of my favorite words in the medical field. Right, so how do you check for blood pressure? Like, if someone could describe it to me, what's the actual process? Start to pump it. When do you stop pumping it? Don't pump up the jams, but do it when you hear some sounds. You stop pumping then. Right, but you got to pump up to a pressure high enough to where you're actually getting no flow whatsoever, right? Right, so you're going to pump up to a point where you're not hearing anything, and that means you're having no flow whatsoever at that point. And then as you start to open that pressure, start to release out, you're allowing for that blood flow to start occurring again. And the highest pressure is when we're going to get that first sound coming back, right? You're going to hear that first kind of sound occurring there, and that's going to be related back to the systolic pressure, okay? So as you start to, that cuff pressure, as it gets low, you get to more of that kind of turbulent blood flow, you get that first sound, and then your systolic pressure is the last sound you hear. Because after that point, when you're listening to those vessels with your stethoscope, you're getting that laminar flow. So again, you've kind of lost that pulsatile nature when you get a high enough pressure like that, or when you're down at the cuff is relaxed maximally. Does that make sense? That's occurring? Okay, you guys already covered most of this. Funny story, so we had to do... Oh, yes, ma'am? Yeah, so that laminar flow basically means the blood is flowing at a very consistent rate. So again, when you have relaxed the pressure on that, you're far enough away from the heart that you're not really going to be getting that kind of pulsatile change in pressure. It's just going to be kind of just flowing at that point. Yeah, good question. So funny story, we had to do some blood pressure... not workshops, but like basically like we set up outside of a pharmacy and we were doing, hey, free blood pressure checks, let the pharmacy students practice on you. And so I got this little old lady, she must have been 9,000 years old. She came up just skinny as a rail. She's like, oh, let's do my blood pressure. And I said, okay. So I ended up putting the cuff on her and I started pumping up and I'm listening. All I hear is this shh, shh, shh. I'm like, what is that sound? This is super weird. And she's like, oh, that's my dialysis trying to think of the thing, fistula. And I was just like, oh, so I could have like totally crushed this thing when I'm like, trying to increase the pressure on that with that sphygmomanometer. I was like, that was not a really good thing. So I did it on the other arm. I was like, please make sure you tell people next time before you check blood pressures, because I thought I could have killed her. Probably not, but in your first year of school, like you probably think you can kill anyone. So yeah, not good. But anyway, so this is how blood pressure should be done at least. Pump it up to a pressure where you're getting no flow. And then as you start to release that pressure, when you get that kind of turbulent flow, that first sound you hear is the highest pressure sound. That's going to be your systolic blood pressure, right? Again, kind of another kind of graphic example of how that sound should be occurring there. But okay, another really important thing for regulating blood pressure is going to be this baroreceptor reflex that occurs. So you guys remember the carotid sinus? This is going to be a primary spot where you see a lot of these stretch receptors actually lying. You're going to find some of them are going to be in the aortic arch, and then some of them are also going to be these carotid sinuses as well. So these are mainly just detecting pressure within those vessels. Okay, low pressure would indicate what, do you think? Probably not enough blood volume. We need to do something to probably increase that pressure versus having very high pressure there being detected. It says, hey, maybe we have too much blood volume. And so this is also going to feed back into some of these regulatory mechanisms like your sympathetic nervous system or like your RAS system and all of that kind of stuff. The carotid sinus is mainly going to be sending these signals through the glossopharyngeal nerve or the cranial nerve 9, whereas the aortic nerve actually sends this through the vagus nerve or cranial nerve 10. So a little bit of difference there in how they get communicated up through the brain. So again, when you have increased blood pressure, ends up stretching those receptors, that's going to increase the number of action potentials that they're sending, right? So we've already seen how kind of mechanical changes in receptors can cause them to have action potentials, kind of similar to the hair cells we saw like in the ear, places like that. But basically that's going to feed back up into the cardiac control centers and the vasomotor centers. And then the vasomotor center is mainly going to be controlling the vasodilation and constriction, so kind of changing that, versus the cardiac center and the medulla is going to be mainly affecting heart rate. Because we mentioned cardiac output, if that's too high, those receptors are going to get activated. We can change both our heart rate, and we can also change that stroke volume as well, based on different changes in our hormones and nervous system. So, again, a fall in blood pressure, you're going to see increased sympathetic and decreased parasympathetic activity, which should lead, you'd have increased heart rate, should lead increased total peripheral resistance. That's going to cause those baroreceptors to stretch more. It says, hey, okay, now we've got the negative feedback loop in place. I'm stretched enough. Now we don't need to release as much of the sympathetic activity. So you have a rise in BP. Or when you have a rise in BP, you have the opposite effects. Too much stretch on those baroreceptors is going to lead you to say, okay, well, we need to either slow down the heart rate or we need to decrease total peripheral resistance, so you can have vasodilation that can occur there. And the problem with a lot of patients over time is that as you have kind of chronic hypertension, what do you think that does to those baroreceptors? Kind of resets them, right? You're going to see this kind of adaptation that occurs over time, and it resets their set point of what's normal for them. So, for instance, normal blood pressure would be considered what? Like 120 over 80 because they're like a normal blood pressure. If you were to have a patient who's chronically sitting at like 160 over 100, like that becomes their new set point for them. And so when you try to drop them down, what does the body end up doing to compensate for that? It has to raise it back up, right? So even though I drop your pressure down to a safe level, based on guidelines and things like that, the body's going to be like, hey, this is too low for us. We should, increase the renin-angiotensin system or increase our total peripheral resistance and all these things. So that's kind of the problem you run into with these hypertensive patients, is that the body's trying to fight you because it's thinking, hey, this pressure is normal now. Don't change it for us. And so over time, you can ultimately kind of reset those baroreceptors, but it takes time. Okay, just another picture kind of showing you again. Say you go, this is really important for kind of acute changes in blood pressure as well. So say for instance you're going from laying down to a standing position, you have decreased venous return as you have kind of pooling occur like in the legs and whatnot. That's going to decrease your end-diastolic volume, which will end up decreasing stroke volume, as we know how that factors into that. So your cardiac output drops. Cardiac output drops, your blood pressure drops, those baroreceptors are not going to be stretched as much, so they're going to be sending signals saying, hey, we need to respond to this by increasing blood pressure. So it's going to be going through the medulla. You'll see that the vasoconstriction of the arterioles occurs here, so that will increase your total peripheral resistance, increasing your pressure, and also cardiac rate's going to be going up to increase cardiac output. Okay. So if I had anything that's like blocking in these mechanisms, what would happen to the patient? They get dizzy and they fall down. Right? So this is kind of the problem we run into with a lot of patients when we give them new blood pressure medications. Because of the fact that we're kind of monkeying around with their ability to respond to changes in blood pressure acutely, we tell them to take their first dose at nighttime. Because otherwise, if they go from sitting to standing, they may be much more affected by this. They don't get that increase in blood flow to the brain. They get dizzy, they fall, get a fracture, and it's no good. So this is one of the things we always want to watch out for, is make sure they can maintain this balance here to respond to those kind of changes in blood pressure. Okay. You also have some chemoreceptors that help to monitor levels of different substances within the carotid artery. Some of the big things we'll look at are going to be pH and also CO2 in some instances. Again, that's going to be sent back through that cranial nerve 9. So think carotid sinus, think cranial nerve 9 for the most part. And these help to maintain vasodilation by changing things like decreased oxygen concentrations. So if you're getting, what's the term for decreased oxygen concentrations? Hypoxia, right? So you're getting hypoxia, then you're going to have decreased oxygen concentrations that should respond by causing vasodilation, right? That allows for better blood flow. Increased carbon dioxide concentrations, you guys know what that would be called? The hypercapnia, right? You guys heard of that term? Hypercapnia is when you have too much CO2 in the blood. That would cause also vasodilation as well, because again, you want to help to get rid of that CO2 as best you can, and also decrease tissue pH. So as it detects that the blood is getting more acidic, typically that means you have more CO2 building up, right, as a byproduct of that oxidative phosphorylation. That can also respond by causing vasodilation to occur. All of that should be increasing blood flow to places like the lungs, where you can get rid of that CO2, so that way you can get more oxygen, get rid of the CO2, and kind of get back to a normal balance state. Okay. And that will also affect cerebral circulation as well. So you can kind of notice here how you have the normal venous and arterial circulation. You can also have blood flow through the cerebral vessels as well. And this is really, really important to maintain this, because again, if you have too high blood pressure or too high a pressure in your CNS, what happens? You have a stroke, like all kinds of bad things. Yeah, so you want to maintain, and the CNS typically likes to maintain pressures in a pretty minimal variance. Like it likes to maintain pressure at a very strict state, and can respond very well in changes in pressure. So when blood pressure initially falls, you'll notice that the cerebral vessels will automatically dilate, right? Because when they dilate, that allows for more blood to get to the brain, which is preferential. You want your brain to keep functioning. As pressure rises, you'll notice that they will try to combat that. They don't want too high a pressure in the brain, so you'll have the cerebral vessels will actually automatically constrict. Okay. Decreased pH of the CSF, or when you have a buildup of CO2. So if you're getting more acidotic, that would cause the arterial dilation to occur, to allow for more blood flow, to allow try to get more oxygen to the tissue, try to balance things out. And then increases in pH. If you're getting too alkalotic, right? Usually a drop in CO2 would be a cause for this. That would cause constriction of the vessels. So imagine if like someone were like hyperventilating into a bag, that would actually end up blowing off a lot of the CO2. They would get more alkalotic. The brain could respond to that by causing constriction of the blood vessels, limiting the change in pH that could occur there. Okay. All right, so again, when we're looking at pulse pressure, basically you can look at the pulse pressure being the difference between your systolic and your diastolic blood pressure. So for instance, if you have blood pressure 120 over 80, your pulse pressure is actually going to be 40, because you just do kind of 120 minus 80, you get 40, right? You could have a higher pulse pressure than that. So for example, if you did 140 minus 80, you end up getting 60. Where do you think this would come into play ever? Or his pulse pressure? So sometimes this can help us out when we're trying to diagnose what the issue is with the patient. So for instance, if they have high blood pressure and they had a very low pulse pressure difference, right? What that means is that their diastolic is probably too high, right? So I can give them medications that mainly focus on getting their diastolic blood pressure down by causing things like venous dilation, so causing them to open up their vein a little bit more. That helps to lower kind of that resting pressure. If an issue has to do with they have a very high systolic in relation to their diastolic, so they have a very high pulse pressure. Sometimes that can be more to things like with the cardiac output. It could have to do with the actual arteries being too constricted. So sometimes you can see that you can try to diagnose differences in the issue based on is the systolic too high or the diastolic too high, or is it both kind of a problem? So you will sometimes do that to try to figure out what the issue is with the patient, and then your treatment may change based on that. Usually you find a normal pressure differentiation there is going to be between 30 and 40 or so. That's pretty normal for the most part. Okay, I'm going to go ahead and finish this lecture out real quick. There's not too much left. I'll kind of go over some of this stuff kind of briefly. Actually, no, I'm not going to do that. I'm actually going to let you guys go now because I have a lecture I have to do at 12:30. So, any questions I can answer for you guys before I let you go? Yes, ma'am. No, I have to upload the other two. I've been delinquent. I'm working on them. I'll have them up before tomorrow. Yep. Any other questions? All right, I'll see you guys tomorrow for a rousing 4 hours physio.